Today we have over 500 students, I want to say about 530 students from area high schools. 11 are from Illinois, and there are 8 Evansville high schools here in attendance. Students, this wouldn't be possible without your instructors and your administration allowing you to come here. So we appreciate the teachers and the instructors who have brought you here today. I tried to get everybody through the Cadaver lab prior to the event. If you did not have a chance to go through the Cadaver lab, at the conclusion of this event, I will be out in the hallway with some of our tour guides that will be able to get you back to the Cadaver lab. I would like to introduce Terry Bruce, who is the CEO of Illinois Eastern Community College, and he would like to welcome you, and then we will move on and get started with this event. So thank you very much.
Thank you all for coming. This is our third one of these events. We're getting better all the time, so come back to the 4th, 5th, and 6th. We'll do it. We have up here Dr. Fulop and Dr. Miller. They're over here, the 2 gentlemen right there. They're going to be the ones doing all the demonstration. And the one that's put all this together, Andrea Law. If you just give Andrea a hand just for a second. Andrea's done a great job, and we want to welcome all of you to Illinois Eastern Community Colleges. We have 4 colleges. Wabash is one, and we're up at Robinson, Illinois with Lincoln Trail, Olney Central, and Frontier down at Fairfield. So we're happy to have you at one of our facilities. And one of the people that make things happen here at Wabash Valley College is Dr. Gill. He's the one that's put this all together. We appreciate Dr. Gill. If you'll come up here, we'll get you started. And while he's walking up, would his family please stand, because they're the ones that have to put up with it every day. 2 daughters and a son and a wife.
All right, I just want to welcome you to Wabash Valley College, and I've got a few thank yous I want to go through real quick. That way we can get on with our presentation. Terry already mentioned Andrea Law. I think Dr. Fowler, the president of the college, is here as well. I'm not sure if he's speaking or not, but I just want to thank him. He's come out here. President of our college. Jerry Baines, the director of our auditorium, and obviously without the use of this facility, we wouldn't be able to put forth a presentation like this today. So Jerry and his crew, we appreciate them. If you're not aware, on our campus, we also have a radio TV broadcasting program. So if you're here helping with that, just kind of wave your hand, the people from that program. Kyle Peach is the instructor here for that, and so they're going to be the ones kind of coordinating the audio-visual portion today, so we appreciate their help. Adam Grosh is our head maintenance. I'm not sure what your exact title is, but he does everything around here. He kind of helped prep the facility. So appreciate Terry Bruce coming. Is Aaron Brown in here, by the way? He's here. He is the, let's see real well up here. He's the president of our Health Professionals Club. And the club kind of this is an extension of our club. We meet once a month, and our goal of meeting is to try to help students be familiar with as many healthcare professions as we can to help them make an informed career decision. And that's part of what we want you to get out of today, being high school students. I obviously have a big thank you to Wabash General for having as many of their staff here. After the presentation, as many of them that can stay around will be up here and available for you to ask questions about their particular career path. And as you can see, a lot of times when you think about surgery, I know for myself, until we started this, you always think about the surgeon, right? And there's just a lot of people that are on this team, both before, even the athletic trainers that are probably some of the first people to come in contact with situations like we're going to be viewing today with a rotator cuff procedure. A lot of people in that entire process play a role in that team. And it is a team to help an individual regain their health. So it'll give you an opportunity to maybe come up and ask some questions about the career path and schooling that was required for that after the procedure is over. So let's give a big round of applause to Wabash General for being here. the teachers and guidance counselors that took time to bring the students today. And then kind of my last thank you, and this may seem a little odd, but she's not here with us still, but our cadaver, his first name was Jean. And Jean and her family, if you're not aware of how people make decisions to be organ donors, and some people make a very important decision to donate their body to science. And so this lady was kind enough and felt it important enough to donate her body for people like us to be able to study on, recognizing that her contribution to the study of healthcare could potentially influence many lives that may regain their health as a result of students like we have here in our nursing programs that are going to go on and participate in providing care to people. And so we ask that you kind of respect that today. At the end, you're going to have an opportunity to come up. We do have a cadaver that has been fully dissected. We'll have off to the stage on the left. You're welcome to come up and view. We'll even have some gloves for those who like to be a little hands-on. My 10-year-old daughter comes in a little bit, studies with me sometimes, so she can handle it. Anyways, I just ask you to be respectful. Obviously, no photography or get in the, with the era, right? No selfies or anything like that with the cadavers. But you're welcome to come up and view them and talk with. Sorry, but I'm just being serious with that. Talk with the surgeons about the procedure and that type of thing, and just, I guess, show your appreciation for the fact that I'm sure Jean, when she made her decision, never probably envisioned the fact that 500 high school students plus students here on campus would have this opportunity. So the last thing I just want to make mention about myself, I guess, is that I'm a 1994 graduate of Lincoln Trail College and went on to chiropractic college. I had a practice here for 15 years before coming to Wabash. And you're going to hear from several people that are involved today that have started their career path either here at Wabash or through the community college system. So I think it's a tremendous opportunity that we have here in our area to provide quality education to students, and I hope that you'll find that today is kind of an extension of that process. So that's all I have to say, so I guess I'll turn it over, take it up to Dr. Fulton. So let's welcome Dr. Fulton.
Guys, thanks for coming today. This is kind of one of the highlights of the year for us to get to put this on. I know where you guys are at right now. It wasn't long ago, or I guess it was a long time ago, but it didn't seem that long ago where I was in high school trying to figure out what I wanted to do. That's where we kind of came up with this idea. The idea of this program was to show a neat procedure, but the more important thing today is kind of what medical careers are out there. What options do I have? And when you're in high school, sometimes you don't even know what's available. You don't know. You know there's a doctor and he goes to school for a long time, but maybe you're interested in healthcare and maybe you don't want to go to school that long, but you still want to be a part of the team. So, the healthcare team is like a chain, and it's only as strong as its weakest link. So if anybody makes a mistake with a nurse, the tech, it can be the housekeeper. Anybody makes a mistake, it can affect that patient. So it's really important that you have a really good team. So you're only as strong as your weakest link. So I'd like to introduce the team that we have, and we'll go through and we'll talk about, each person will have a chance to talk, and we'll tell you kind of what school they went to. So you may not be interested in being a doctor, but you may be interested in doing something in healthcare. So today we're going to do a shoulder surgery, but we'll kind of introduce the whole healthcare team as we go to kind of let you know what career options are available. There we go. Okay, we're going to take you through the team today, which we've got an athletic trainer here, sports medicine physician, your radiologist, radiology tech, orthopedic surgeon, we've got anesthesia, nursing, scrub tech, pharmacist, physical and occupational therapy. And that's really what it takes to get somebody through an injury surgery, to doing well, okay? So we'll kind of just start with a story of somebody hurts your shoulder, and we'll kind of take you through the whole process, okay? So let's just say you're a high school student and you're playing a sport. It can be any sport, and you hurt your shoulder. So,
baseball.
Pardon me?
Baseball.
Baseball, there you go. You're a baseball player. So that's another important thing. If you guys have a question, blurt it out. You can read comments to yourself, but if you have a question, raise your hand, get my attention, and we'll get it answered for you, okay? So you're a baseball player, and you hurt your shoulder. So you tough it out for a little while, and then you decide, I can't do this anymore. My shoulder, it's bothering me, I'm not throwing like I should, I'm going to be benched. So the first person you'll probably see at most high schools is you'll see the athletic trainer, right? And how do you know who the athletic trainer is? Fanny pack, right? You always seem to have a fanny pack. So that's how you know who the athletic trainer is. So we're going to have Rachel Stevens. Where's Rachel? Rachel's our head athletic trainer. She's going to talk to you a little bit.
Hello, I am Rachel Stevens. I'm our athletic trainer coordinator, certified athletic trainer for Wabash General Hospital. I actually have 3 of my co-workers with us today. Sarah Sleneker is our athletic trainer at Fairfield High School. And then Sam Hodges is our certified athletic trainer here at Mount Carmel High School. We have one more athletic trainer who is not here today. Cassie Colthouse is our athletic trainer for Lawrenceville High School and Red Hill High School. I myself cover Edwards County High School and Grayville High School. And then we also cover, Sarah also covers Frontier Community College. So we have 5 athletic trainers on staff. We cover 7 area high schools and 2 junior colleges. I am a graduate of Edwards County High School, graduated in 2000. Got my Bachelor's of Science in Athletic Training from Indiana State University in 2004. Still going strong with a great program in the U.S., by the way. So if you're thinking of athletic training, check out Indiana State University. Interesting fact, I actually wanted to be an orthopedic surgeon when I started out in high school. And then we had biology class, and I found out I couldn't even cut open an earthworm. And so I was like, there's no way I'm cutting it to a human body, especially when we cut it to the pig. That was all bets were off, but I ended up having to cut it open because not only was I sick of it, but my lab partner was even more mortified of the thought of cutting into something. So I actually wanted to be an orthopedic surgeon, but that just didn't happen. I actually had 2 ACL reconstructions in my high school career. I had one on both legs. Went to physical therapy, thought about, well, hey, I'll do physical therapy. But they dealt more with the general population, and I wasn't really interested in dealing with everybody and their issues. So one of my athletic trainers, or physical therapist, was an athletic trainer. So I said, well, what's athletic training? So that's how I got started on the path of athletic training, checked out different schools in the area. Indiana State had one of the better programs, one of the best programs in the nation. So I said, hey, let's go to Indiana State. Happened to get accepted. And with your athletic training program, well, again, I graduated in 2004. Things have changed since then. But we started out with 100 people at Indiana State who were interested in the profession of athletic training. You applied to the program your sophomore year. This was at Indiana State, so it might be different. But your sophomore year, you actually applied to the program. So you did 2 years of general education, and then you actually had to apply to get in. They took 12 applicants. By the time we got to apply to the program, we went from 100 people interested in athletic training to 14. And they only accepted 12. So that's how high the stakes are in medical profession, okay? So you don't always get in and they weed out the bad ones through your science classes and your biology. Well, biology is science, but science and math, okay? Because you have kinesiology, you have anatomy, you have physics, which include physics, okay? You're going to do chemistry. But, so that's just a general overview of what you can prepare to expect when you go to college. Now, I'm at Edwards County High School. My typical day is I go to the high school, I'm there for treatments. Athletic trainers, we evaluate, treat, rehab injuries. We're not just pertaining to the athletic field, but in our case here with Wabash Valley College or Wabash General Hospital, we deal with the athletic population. We also work in industrial settings, we work in the military, we work with law enforcement, we can work in liberal arts, so like your ballet, dancing, things like that. What else? Other areas. I think that's kind of the general. So athletic trainers just are not in professional sports. They're not just in collegiate athletics. They're not just in high schools. They're all over. We can do a a number of things. We can benefit the community and the job workplace in so many ways, okay? So, but with our typical daily schedule, I'm at the high school. I'm there to treat athletes who have either been injured, or as Dr. Phillips said in this scenario, you might be a baseball player who's like, well, you know, my arm, my shoulder, I've been pitching for about 2 weeks now, and it was feeling okay, but now I'm just, there's something going on, and I don't know what it is. So you're going to come and see me. I'm going to evaluate. Now, the best thing, one of the great things about working in an environment with Wabash General Hospital, sorry we're at WVC, is that we're all going to do things very similar. And that is better for your care. Because the more continuity of care, so the more the same care you get, the better outcome for your return to play. Okay? So I'm going to evaluate you. I'm going to determine, can we take care of your issue with therapy? We can do rehab. Athletic trainers can do rehab in the school setting, okay? We can give you exercises to do. We can do treatments on you, so like TENS, ice, heat, range of motion exercises, you name it, we can do it. We can see, are you going to get better with that? We might take you through like 2 weeks. If you're not progressing, I'm going to say, you know what? We're not getting any better, and now your strength starts to decrease, your range of motion isn't getting any better, and so maybe it's time to go see the doctor. So then I'm going to call up and I'm going to say, hey, I got John Doe here. We need to have him see Dr. Slater. Dr. Slater is actually our sports medicine physician. Do you mind if I go ahead, or you want to introduce him? Okay, and so I'll say Dr. Slater needs to see this athlete. So then they're going to go see Dr. Slater. So then Dr. Slater, do you come up? So then he's the next road mark, or the next.
Hi guys, Carson Slater. I'm the primary care sports medicine physician, which is a mouthful to say that I'm a primary care or family physician who's gone back with an interest in sports medicine, got additional training. I may be one of the docs you see along the way. You may see your primary care doc first, and that's okay. That's part of the process. Everybody doesn't come directly to the specialist right away. Your parents or family, whoever may say, hey, let's let our doc, we know our doc, let's get their opinion first. And that's perfectly fine, that's great. They're going to evaluate you, or if you come see me, we're going to evaluate you, get that initial evaluation. Do we need to do more? Is the trainer's concerns valid? So at that point, we may decide, yeah, you know, you need to rest a little bit, let's give it a little time, let's see what happens. We may have some genuine concerns that there's a little more going on. We may order diagnostic testing, MRI. We may order physical therapy. We think it's something that's just going to get better with time. X-rays, and we're going to turn that over in just a minute. But I'm going to explain a little bit more about some of the options from a primary care standpoint. Yes, doctor, and I'm not going to bore you with my long history. Okay, lots of school, lots of decision makings. I will say this, guys, there is no limit, no age limit on learning. You may not know what you want to do, and it's okay. I didn't know what I wanted to do right away. I started off in engineering, believe it or not. Changed my mind, said, nah, that's not for me. I went back to school, many years later decided, you know, I really like science, I like biology, I like the body, maybe medicine's where I need to be. And I sought it out, and sure enough, found something that I loved. So just remember that you don't have to have all the answers now. Most of you will change your mind several times before you even get through college. So just stick with it and find what works for you. Okay? But primary care doctors, in contrast to orthopedic surgeons, okay, a little bit different, so a lot of people don't know how that balances out. I don't do surgery. I do sports medicine, do the non-surgical part, which can be sometimes, Dr. Fulp, up to 80%.
Yeah.
I think it's the kind of the general number thrown out there. A lot of your orthopedic injuries and stuff don't require surgery. And so that's kind of what I spend most of my time doing, handling the non-surgical approaches. I still do some fun stuff in the office, injections and casting and splinting. I can do toenail removals, okay? It's not glamorous, but it helps the patient out. So there's a lot of fun things you can learn to do, even with special equipment like ultrasound. We can do ultrasound-guided injections, and if you go and get additional training, you can actually diagnose rotator cuff tears or other injuries through ultrasound that don't require an MRI or some of the other costly procedures. But I coordinate with the athletic trainers. I help supervise our 5 trainers and just try to get open communication. They're out on the field and they get an injury, they're going to call me and say, hey, this is what I got. How quick do we need to get them in? Can you stop by and see them? Those kind of things. So I'm available through the trainers pretty much at any point in time. And that's the beauty of cell phones. But they know that. And a lot of times they'll just bounce something off that we have been working with this kid for several days now. It's not really going well. I thought it was just this, but there may be more to it. Do I need to get them in? You need to take a look at them. And so that's my function in this role, is to get the kids in, get a good evaluation, say, hey, is this something a little more? Do we need to get that MRI? Is this something that may be surgical that I'll need to send to Dr. Fuller, Dr. Miller for that final treatment? But you see, guys, there's that progression of care, and it takes this whole team. One person can't do it all. And like Dr. Fuller said, everybody's got an important part in this process, and a breakdown at any point is can be detrimental to the patient. I think. All right. Any other questions? Anything real quick? Okay. So we're going to pretend we did an MRI. Right. Going radiology. Okay.
So, back up here a little bit. So now you're at the point where you come to see me or Dr. Miller or another orthopedic surgeon, okay? And to make this a little more factual, today we're going to look at a rotator cuff tear because it's easier to demonstrate on a cadaver. Rotator cuff tears are actually very uncommon in younger individuals, athletes. Actually, below age 30, you rarely ever see them. So the more common thing that an athlete would have, like a baseball player would be a labral tear or a capsule injury, a shoulder dislocation, one of those things, which is really hard to demonstrate in a cadaver, so we're not doing that today. So most rotator cuff tears actually occur in the older population, older being old like me, 40 and on, right? So, and we actually see them the highest in our 50 to 60 year, 50 to 70 year old age group. So when you come see the doctor, what you're going to do is we're going to do some exam tests, right? And that's how we figure out what's going on. So you know, we can't just kind of see through your skin. We have to use our training and use any skills that we have, anything we can do to kind of figure out what's going on with you. So it's like a puzzle. That's what it is. It's really a puzzle that we're trying to figure out. And put that in perspective with your health and everything else that's going on with your life and your function. So we mostly use exam tests for most things, and that's ways that we can maneuver the joints of the body in a way to try to figure out, okay, what's torn, and how do we know this stuff? Well, we go to school for a long time, and we really do a lot of work with anatomy. We have to understand how the muscles work, and the bones work, and the joints work. And really what orthopedic surgeons are, we're mechanics of the human body. So when something breaks, in your axial skeleton, which is every, outside your internal organs, then we're the ones that try to put that back together. And sometimes it's broken so bad we can't get it back together right, and sometimes we can't. Sports medicine is one part of orthopedics. There's a lot of other parts of orthopedics. There's trauma care, there's hand surgery, there's spine surgery, there's orthopedic oncology. The field is expansive, and it goes on and on and on. So again, we're looking at one small part of that. So when someone comes in to see us, we're going to do some exam tests, we're going to take a history, and we're going to try to figure out what's going on. So one of the things with the rotator cuff is the exam. And so what we're going to see is, I messed it up again. All right. So one of the things we're going to do is a test where we just raise your arm up and we have you bring your arm down. See how his arm drops and his shoulder elevates? Okay, that's the sign of a big rotator cuff tear. So if we see that, and we rarely get to see that, but that tells us, well, we've got a big rotator cuff tear. And most rotator cuff tears don't present like that. Most of them are much more smaller and subtle, and it's something that is a lot harder to figure out. And that's a pretty obvious one. So what is the rotator cuff? Or rotor cuff, or rotary cuff, or you probably heard a lot of different names. The rotator cuff is really slang. There's nothing in medicine that's actually called the rotator cuff. All right? The rotator cuff is a series of muscles that, and it's 4 muscles that surround the humeral head. And then the shoulder joint is the glenoid, which is the socket, and then you've got the ball, right? And then you've got 4 muscles that kind of control that. If you think about the shoulder in relation, or compared to a hip joint, with the hip joint you've got this big acetabulum, which is very constraining, and then you've got the ball in there. And the acetabulum is what controls the motion, or makes the joint stable. Whereas in the shoulder joint, you've got this little bitty socket called the glenoid, and then you've got this humeral head. And the shoulder has got all this motion, whereas the hip doesn't have much motion. Okay? So what controls that motion is all the rotator cuff muscles. Okay? There's 4 muscles for the anatomy students. There's the supraspinatus, the subscapularis, the infraspinatus, and the teres minor. Okay? The supraspinatus is the one that's most commonly torn. And you can tear them in all different ways. They can be traumatic, they can be atraumatic. So lots of patients come in and they can say, I never had an injury, but my shoulder hurts. And if they're in the right age group, most of the time it's a rotator cuff tear. Most tears that we see are actually atraumatic. They don't have a fall. They don't have an event that happens. They can have pain. They can have difficulty moving. It can be all sorts of different ways that they can present. And if we look at the muscles, there's the supraspinatus at top. Again, it's the most common. The infraspinatus on the bottom, below the spine here. The subscap's in the front, and then this little muscle in the bottom is the teres minor, which is innervated by a branch of the axillary nerve. And then the glenoid, with the humeral head removed, that picture on the bottom there is the glenoid, which is, again, very small. So here's a video showing what these muscles do. The supraspinatus and other cuff muscles essentially bring your arm in a position that your deltoid can now function. So if those muscles don't work, the deltoid never gets a chance to fire. It never gets a chance to bring your arm up. So many of you may know an older person, especially in a nursing home, they try to raise their arm, they just kind of do this. And those are individuals that have a rotator cuff tear, or a supraspinatus tear. So as orthopedic surgeons, the first thing we're going to do is get an x-ray. And here we see, this is a pretty normal shoulder x-ray, and that's what we see with most patients that have a rotator cuff tear. And over here on this side, we see a shoulder that's arthritic. So some things you can see with x-ray, and some things you can't. So the normal shoulder, we really don't see a rotator cuff tear, or a supraspinatus tear. But that's kind of what we're suspecting with this patient. Something like this, that's a whole different problem. Usually that would end up with a shoulder replacement surgery. So some things you can see on x-rays, some things you can't. So if we really thought it was a rotator cuff tear or supraspinatus tear, we would go on to get an MRI. And MRI allows us to see soft tissues. And here's an illustration of what a supraspinatus tear would look like. You can kind of see the muscle. You can kind of see where it's torn, right at its attachment site, or where it connects to the bone. So we get an MRI. MRI is a great big magnet. And has anybody in here ever had an MRI? Right? So you lay in this little tube, right? It's a little bit scary. It slides you in. It's a great big magnet. And all an MRI does is an MRI looks at water. And it looks at how much water is in different tissues. And it gives us gradients. And those gradients allow us, we put those up in a computer, and it comes up with an image. And here we can see, just like that picture, we see the humeral head, we see the supraspinatus, and then there's our tear. So there's nothing magic to that. It's, we go to a lot of school about it, but a lot of it's understanding your anatomy, understanding kind of what you're looking for in the whole disease process. And then, so we've kind of gone over that, the 4 tendons. Here's another illustration of what they're trying to do. It's also a good illustration of what makes up shoulder motion. So when you raise your arm, a small part of raising your arm is actually the shoulder joint itself. Okay? As you see in the illustration, the scapula actually moves too. Right? So the scapula is a big part of raising your arm and moving your arm. So part of the rehab is to rehab the scapula. And part of understanding the shoulder is understanding that the motion also comes from the scapula. So your rotator muscle can still be torn and you can still do this. You can still get that arm up. Okay? Because that's all scapular motion. So we get to a point where we're going to do surgery. So I'm going to have Dr. Miller and our surgery team start doing surgery here, and I'll kind of talk through it. But this is one of the pictures that we see when we go into surgery. So with cuff surgery, you can do it open or you can do it through a scope. A scope being a little small camera that you can poke in through a small incision. Open, big incision, which usually goes on for rehab and more time recovery. So when we look inside the shoulder joint, we see this would be the humeral head on the bottom, which is the cartilage, and then like here's the biceps tendon in this picture. A normal rotator cuff comes down and inserts. So we look at that and say, well, that's normal. And then another person, like our person today, we're going to look inside there and say, hey, look, there's a big tear. Because this tendon should be down against that humeral head. We should see the tendon. We should see it down here. Okay? And then there's another picture. Now that's looking from the outside in of a rotator cuff tear. So you need to close that hole, basically, and sew it back down to the bone. And that's the whole idea of surgery here. We're going to go in, we're going to grab this tendon, we're going to pull it down to the bone, and then we're going to ask the body to heal it together as they work together. Okay? The importance to that is to understand that if you have a full thickness rotator cuff tear, or a tear that pulls all the way off the bone, it's never going to heal because it can't bridge that gap. Okay? The muscle can never go back to the bone once they're apart. They have to be touching. Now you can have a partial thickness cuff tear, and that's where it only tears part of the way through, 25%, 50%, but it's still attached. And those can sometimes heal. And that's where sometimes before surgery we'll do therapy, we'll try cortisone injections, we'll try those kind of things. So that's what that tear looks like after you fixed it. We put an anchor in and some sutures up through it. And then here's an illustration of how we're going to repair this today. And while they're getting started, they'll get started here in a second. And so here we took the muscle and the skin away, and we've got a cuff tear. And you can see the tear right there. It's being grabbed by an instrument. These little guys out here are cannulas that go through the soft tissue, and they allow us to come in with our instruments. Okay? So we've got a cuff tear. You're going to come in with an extra incision and poke a hole. And you're going to come in with an anchor. Okay? And then when you pull the anchor out, you've got these sutures that are attached to the anchor. And those sutures are so strong that you can like pick somebody's body weight up with them. They're pretty amazing. And then we pass the suture up through the tissue with this little suture passer. It works just like a sewing machine needle. And we pass the tissues out. And we pull them back around. We're going to do a second suture through. There's hundreds of ways you can fix these. We're going to do kind of what's shown in this picture today, or this part of it. So there's a second anchor, then passing the sutures through, and this is for what we call a double row repair. And then what they didn't show there is that you tie the sutures. So you tie the sutures on the outside, you slide them in, and then they're doing a second lateral row here. So these little tubes and all these instruments are kind of like building a ship in a bottle. We get to do this surgery inside somebody with all these fancy instruments and all this fancy equipment that we'll kind of go over as we go through the case here. And in this case, they plug, with the illustration, they plug them into the lateral row there. Any questions from anybody? Okay. So, first I'll point out, as Dr. Miller's getting started, switch over to that. So Dr. Miller's just getting started here. So first we'll point out, and again, there's not a good chance to see the cadaver now when we're done. If you guys want to see the cadavers closer, you can come up and see them. Okay, so the patient's draped out, and all we can see is the arm. That's what it's like in no surgery. We just see the arm. Sterile technique through everything. I'm going to focus the camera here. And I'll talk a little bit about the setup. So we've seen these bags that are hanging up here. These bags are normal saline, which is like salt water, right? The same consistency as the human body. And we run those through a pump. And the pump is what keeps the pressure up in the shoulder. So we make these little holes in the shoulder, and then we put these tubes in, we pump it full of fluid. And that fluid is running through the shoulder constantly, and that clears the blood out or anything else, and it allows us to see. So that's how we can visualize inside the shoulder. So if you're in the belly, it's different. You'll use the gas, you'll use CO2 gas. So every type of surgery has different types of scopes, and they're all very different. But in orthopedic surgery, we always use saline. So at this part of the shoulder, he's looking at the, so that's the humeral head that he's pointing to here. This probe, to put things in perspective, that probe is about 3 millimeters thick, okay? And it looks huge up here on the screen. So he's pointing to the glenoid now, and the glenoid's on this side, so that's the socket side, right? And then the humeral head's on the other side. So that's looking inside the shoulder joint. That's what we see. He's pointing to the anterior labrum. Right there's the anterior labrum. The labrum is like a bumper on the front of your shoulder. And that's what tears when you have a dislocation. Okay? The most common direction the shoulder dislocates is anteriorly. So you tear the anterior labrum. That's some rough looking arthritis there on the head. There's a biceps tendon. So you'll be able to see the long head of the biceps come in. So that's the long head of the biceps right there. The long head of the biceps is very unique in that there's only 2 tendons in the human body that insert inside a joint. One is the long head of the biceps, and the second is the popliteus muscle, which is in the knee. So there's our cuff tear. Can we go back to the subscap? Can you see the subscap? Might internally rotate a little bit. So, biceps. So, arthroscopy can be a little frustrating because it's hard to see. A little bit of bleeding, the stuff swells, it gets in your way. But I'm just trying to show you the normal subscap muscle. The shows look really good. There it is. Right there, you can see that muscle. There's a normal subscap muscle. See how that inserts into the bone? So that looks good. So, and when we do a shoulder scope, we look at everything. We put a scope in, we're just not looking for a cuff tear. We're looking for any problem we can find that we can make the patient better. So the cuff was torn, so now we're going to come up in the subacromial space, which is below the acromion, and we're going to get a picture here pretty soon. While he's doing that, let's go to the camera here. Let's look at some of this equipment. Can you do that? Can we switch to the floor camera? Justin's telling me to read. Does it work? Stop flipping. Okay. That's right. How do I do it? So I'll just talk about this while he's getting a good view. So we've got a pump, we've got this video tower, we've got this thing we call R2D2, which is a big suction apparatus. We've got all this technology in a box, which is about $60,000 to $100,000 worth of instrumentation. The hospital let us go out here today. We were very grateful for that. And so it takes all this equipment, and then it takes all this staff that has to know how to use this equipment. And as part of our surgery team, we have several individuals. There are, in the hospital, in surgery, we have techs and we have nurses. Okay? The nurses are kind of in charge of the case from the patient standpoint. And And then we have techs, and the techs are in charge of the instruments. The techs, they clean the instruments. They're the ones that make sure all the equipment's there, make sure we have everything we need. And on our surgery team, we have Sabrina. Sabrina Waldrop, raise your hand here. And she's kind of our dual-purpose gal, where she's a nurse. She went to Wabash. She has her associate's degree. She's an RN. And then she learned how to be a tech as well. So she kind of fills two roles for us in the OR. We also, if she's a tech, we also have to have a nurse there as well. And her job is arguably one of the more important jobs in the OR, and that is making sure everything's clean and cleaned properly. And we have all these sterilizers and all these fancy equipment to make sure that all of the equipment is absolutely sterile and is handled in a perfect way, that it never gets contaminated before it gets set on the table, so then we as surgeons can use it during the case. And they do their job perfectly, and if they don't, the patient has a very bad outcome and can even die. So it's a very important job. Surgery tech school is a 2-year program, and we've hired numerous techs from the local programs. It's something that we have to have, every surgery program has to have. So some individuals may not want to be a nurse, and they may still want to go, they still may want to be in the operating room setting, and tech school is a great option. So, and sometimes we have a hard time finding a tech, so it can be a job that's in demand. So the next, so the other individual that's on a surgery team, in our case, is Chelsea Hahn. She's a PA, and a PA is another great option to participate in healthcare or have a career in healthcare and not go to medical school. And what a PA is a physician's assistant. So they're a master's level program. They're physician assistants and nurse practitioners that can both, they go to school, they go to college. In a PA's case, they go to college. Chelsea went to Wichita State for 4 years, and then she went on to a PA program for 2 additional years. And when they're done, PA program is a lot like mini med school. So they do medical school rather than 4 years like we do it, they do it in 2 years. And when they're done, they get to do basically everything that a physician can do, but they have to be working underneath a physician. They have to be supervised by a physician. So Chelsea comes to surgery with me. Every time in surgery, she sees patients on her own. She signs patients up for surgery. She makes decisions about surgery. She takes care of post-op patients. She sees athletes. She gets to do pretty much everything I get to do. And she helps me provide more care to more people. Okay. So we've got the cup here. Dr. Miller showing you the cup, just like we saw in that animation. And he's using a grasper to kind of hold that, and you can you show where it goes down to the bone? Yeah, so the cuff goes down to the bone down there. There you go. There's where the cuff goes, right there to the bone. So we're going to make another portal here. There we go. And that looks huge. It's just a simple needle. And we'll make another portal. A portal is just a little hole in the skin that allows us to get into the joint. So now we're going to make we're going to put a cannula in, just like you saw those cannulas in the animation. The little tubes that allow us to get in and out of the joint. and the whole time this is going on, you know, the other people that we don't have represented today would be like an anesthesia provider. We have the pre-op and post-op recovery room nurses. With the anesthesia providers, you can be a medical doctor, or you can be a CRNA, which is a registered nurse that goes on to anesthesia school, and that's what we have 3 registered nurses or CRNAs at our hospital. So, there we go. So we're going to, just like in that animation, we're going to punch a hole in the bone. And then we're going to, once we get that hole punched, we're going to come in with an anchor. And the anchors are, there's all different types of anchors for all different purposes. And the anchors that we mostly use nowadays are made out of the same compound, essentially, that bone is, the same crystal structure as bone. So when we put them in, they're absorbable, they're bioabsorbable, so that means your body actually gets rid of them or converts them back to bone over the course of the next year or two. And the anchors, then you can kind of see the anchor. Again, it's tough to see. The anchors kind of look like corkscrews. So the anchor gets screwed in, which is, again, tough to see sometimes because the soft tissue pushes down in the way. And there's the the insertion handle. And then when we pull the insertion handle out, you'll see some sutures, which are like little ropes or pieces of string, and that's what we're going to do the repair with. So there's the strings, or the little ropes. And just like in that picture, we're going to grab those little ropes. We're going to pull them out of the cannula. There we are. Again, this stuff is really tiny. Like those little ropes that look huge, they're maybe a quarter of a millimeter in size. And then we're going to put that on a passer, which is like a sewing machine clamp kind of needle. And we're going to take that and punch it up through the cuff. So who in here knows what they want to be when they're done with school? Who knows what they want to do? Right? You got a bunch of hands going up. So it's okay to not know what you want to do. Right? So most people, most kids in high school, it's hard to know. It's hard to realize what you want to do with the rest of your life because you haven't experienced a whole lot of things. Right? So, you know, with most professionals in any field, it will not be very often they turn you down if you want to spend some time with them. So no matter what you want to go into, if you want to be a mechanical engineer or a firefighter or whatever that is, go check that field out. Go talk to those individuals. If you want to be an accountant, go talk to an accountant, spend a day in their office, see what they do. You know, we have students all the time come to us and say, hey, I think I want to go into medicine. Well, come spend the day with us in the clinic. You know, come see what we do. And a lot of people will change their mind. And it's a lot better to change your mind early on than it is later on in life when you've already spent 2 or 3 years in school, and you pay for all this school, and take all these classes that you need. So it's a really good thing to talk to professionals. Most professionals welcome students and young individuals coming in and talking to us. So up back to the screen, he's got this big clamp-looking device. He's going to pass it over around the rotator cuff there, up through it. And again, it's very hard to see in cuff surgery. And he passes the needle up through, and hopefully it passed. The other thing to mention too is that anybody that thinks they have their mind made up, almost everybody changes their mind multiple times, again and again. I know I did. So it's okay to not know what you're doing. It's okay to think you know what you're doing and change your mind. So, keep an open mind, different career opportunities. The sky's the limit. So we've got the suture pass through. Trying to do a suture pass through the tissue here. Did it work? Which is again hard to see. Cadavers are really hard to operate on because they don't have normal tissue tension, and they get real fuzzy really quick. So again, there's a grasp and grabbing suture. The other thing I'll say is that you can do anything coming from a small town. Okay? Lots of people find that it's intimidating to go to a bigger college and think that, well, I don't have the education, I don't have the background, I didn't go to a fancy high school prep school, and that's not true. So Dr. Miller here, he's from Grayville. He went to Wabash Valley College. He went on from there to Louisville, and then from there to medical school, and then he did his residency up at Indianapolis. And it's not an easy thing to get into an orthopedic program. So it's not easy at all. So, most big programs have 3 or 4 residents a year, and that's it. And sometimes there's 3,000 to 4,000 applicants for those 3 to 4 positions. So, here I'm from a small town. I grew up right down the road, and I was able to go into orthopedics. Dr. Miller is from Grayville. He was able to go into orthopedics. So you can do anything you want if you put your mind to it and you work hard enough. And that's the big thing. You have to work hard enough. You have to put in the hours and the time when you get to college, especially, to do as well or better than the other students. So when then you go and get into medical school, or you have a chance to do medical school. So to go into orthopedic surgery, it's you go to college, you get a 4-year degree, you go to medical school for 4 years, then after medical school, then you have to do a residency. And when I went to medical school, I didn't even know what residency was. I thought I was done when I was done with medical school. But then you have to go on to residency, which is on-the-job training. And on-the-job training goes on for 3 to 5 years, or 3 to 7 years, depending on what you go into. The surgical specialties take a longer time. And for orthopedics, it's 5 years. So you're 5 years after medical school before you're out on your own. So it's like the longest adolescence that in any profession. And you take baby steps. This stuff is kind of scary, but you don't start off doing surgery the first day. You start off getting to put a single stitch in. And then the next thing you know, you put 2 stitches in. And the next thing you know, you're taking baby steps to learn how to do this, learn how to do that. And you're reading a lot. You're not sleeping a lot, but it's an adventure. It's like climbing a mountain. And it takes 5 years after medical school to climb that mountain. So, how's it coming? Okay, yeah. So we've got the So we've got the suture passed through the tissue, and now we're going to tie. We're going to tie the suture. Can we switch to the outside field? Is it working? Okay. Having some technical difficulties. There we go. Yeah, here we go. Can you zoom in on what he's doing here?
So obviously we can't put our hands in to tie these knots, so we use this instrument here called knot. That's what helps us to tie these knots within the shoulder. So I'll show you this one, you guys can
So he's going to tie a knot on the outside, and you can actually watch him tie the knot, and then we'll go back to the inside view. So what we do is we pass the sutures, and then we tie the knots on the outside of the body, and we slide those knots down. Okay, so we tied a knot there. Now let's go back to the inside feed. Okay, and now if you watch, you can see the knot sliding down. There's the knot, you can see it. Kind of right there's the first knot, and he's going to tie a second knot here in just a second. There's a second knot coming down. He's going to tension that knot. He's basically going to pull the tissue down, and that'll pull the tissue back down the bone, which is the reason we showed you the illustration, because it's really hard to see, and this cadaver especially makes it difficult to see. But there you can see how we tied the knot inside. This is a knot cut. This is a cutter, so it's going to go down and cut the sutures. So it cuts the sutures, and he's left with just a knot. So that was one anchor and one suture, and oftentimes when we do a rotator cuff repair, we'll use anywhere from 1 up to 8 or 9 anchors, and each anchor can have up to 3 sutures in it. So the process goes a lot faster than in a real life surgery on a real person, but it can take some time. And so rotator cuff repairs through a scope can take a couple hours, and that's pretty much the norm. So after we fix the shoulder, after we fix the cuff, they'll go in a sling. Sometimes we put them in therapy immediately. Sometimes they're in therapy, or they're in a sling for 6 weeks before we remove them, depending on the size of the tear. And that's all based off research papers on how they do and the decisions that we make. So we have a second suture that's passed up through the tissue, so we're going to slide a knot down here as well. So there's the knot there. You can see it pulling the tissue down. And again, tying knots, they're nothing too fancy about the knots. They're just good square knots. But they have to be really good square knots, or they come untied, and then all that work that we did is for nothing. And they don't do well, and it has to be redone. The cuff repairs can fail for numerous reasons. The tissue can be poor, if the patient comes out of a sling too early, if we don't do a good job repairing it, if the knots weren't tied right, if there's too much tension on the cuff. So there's lots of reasons that can fail, and that's our job as professionals, is to try to do a good job and try to set the patient up to do well. So At this point, the patients, we're done with the surgery, we put in the sling, they'll go to the recovery room, they'll see the recovery room nurse, they'll wake up, they'll go home from there, and they'll see a physical therapist at some point based off how bad their cuff tear is. And so I'm going to introduce Andrew Kleinschmidt. He's the head of our physical therapy department at Mount Carmel, Wabash General, and he's the one that put together most of the slides today.
Hey guys, please switch that back. All right, Phil, you got that clicker?
Yeah. I'm going to give it up.
Hi everybody, I'm Andrew Kleinschmidt. I'm a physical therapist and head of rehabilitation out of the hospital here. So the challenge with this is, I've got a fresh cuff repair. If they come back day one or day two post-op, how in the world are we supposed to get this, what they just did, back up to here, back down to here? So that's kind of my job. I've got to figure out what kind of different movement patterns are necessary to get, like you saw in that animation, it's not just the shoulder joint, so I've got to work with the scapula, I've got to work with the little humeral joint, I've got to make sure that there's no compensatory movements, because maybe for a long time, these patients have been doing this. I've got to figure out, okay, now we got a brand new repair, I've got to get it back up here. So it's a really, really cool field to be in. I was a graduate from Wabash Valley College here, graduated in 04. From Grayville, like with Dr. Miller. Dr. Miller and I played ball together, worked for the city together. It's been a really cool experience to be able to start out in a hometown and come serve my own communities. So that's been probably the highlight of my career, just being a part of the small communities. I really enjoy anybody, like Dr. Miller or Dr. Phillips said, if you have an interest in what I do, I'm always happy to have you come into the clinic and spend a day with me or some of our therapists. We really enjoy teaching and showing people what we do, because this is a field that is extremely variable in what we can do. A lot of us work in orthopedics, several of us will work in pediatrics, oncology, sports medicine. So we see a very wide variety of patients, geriatric all the way down to newborns. So one of the things that we, Dr. Slater and I have been working on here recently is more in the athletic training domain, performance enhancement and movement impairments, injury prevention, I should say. So one of the cool things we've been learning in the past 10 years in research is why do you have high-level athletes that can play and do all these awesome things, running, jumping, spiking a volleyball, hitting a baseball, pitching. Could they be better? And what we've been finding is we break down movement patterns and find that they're really kind of screwed up. And they're at big risk for injury. So one of the things Dr. Slater and I have been working on together is a program where we can tease out these specific movement patterns and find deficiencies and be able to make an athlete perform a lot better. That's been a really cool part of my job. But a lot of it is just forming relationships with people. You get into people's business doing this stuff. Just to make somebody move again and feel better, that's extremely satisfying. So it's an awesome field, and I encourage you, if you want to know more about it, but back to rotator cuff. So I've got this new cuff, repair, and probably about anywhere between 8 to 16 weeks, depending on the patient goals. If they're a young patient, we like to get them back to maybe playing tennis. That'd be quite a lofty goal, but with time and proper therapy, they could probably do that. Some people at this age, they just want to be able to reach up in their cabinet and grab a can of something. So it depends on the patient's goals. So one of the things that I can do to really make an orthopedic surgeon upset is to go too fast and rip this new repair. So I don't want to do that, definitely. I'll probably lose my job for that. But, so how do I do it? Well, that's where schooling comes in. I went to school for about 6.5 years, learned basic anatomy, physiology, biomechanics, kinesiology, and I've got to know not only all that stuff, but how does a tissue heal itself, and what's the appropriate time to do certain things. So there's a lot of things that go into it. Some of the things we might do after a rotator cuff repair. One thing I love about shoulders is how hands-on they are, and you can't be a physical therapist without being handsy. Sorry if that sounds weird, but the other thing about our schooling is we are transitioning from a master's degree to a doctorate degree. That's really already happened. So I was the last master's degree to graduate from the University of Evansville, and you can get an idea what it costs to go there. Anywhere between $15,000 and $170,000 now, depending on if you go to public or private school. GPA 3.5, heavy emphasis, like I said before, on biology, biomechanics, kinesiology, anatomy, and gosh, I mean, in this field you can go anywhere, you can do anything, treat any type of patient you want to treat. It's really cool. So anyway, I wanted to highlight too occupational therapy because with shoulders and anything upper extremity, as far as our clinic goes, we kind of share those responsibilities. So I want to introduce Ryan Worrell to you. He's our occupational therapist. Come on out, Ryan. Nice introduction, all right.
Sorry about that. Yes, my name is Ryan. I'm an occupational therapist. And kind of like what Andrew was saying there is occupational therapists primarily look at least here at Wabash General, we're looking at the upper extremity, the arm and shoulder. Thanks. But what all does an occupational therapist do that is particularly challenging to explain? The field is so diverse, it is really kind of tough for me to explain what this is. But one thing we are not is we are not to find you guys jobs or whatever. I can't even tell you how many times I've had patients come up to me and say, I don't need a job, why are you here? Well, that's not exactly the case here. I'm not a vocational therapist, although that is part of what I may do. I may help you get back to work or whatever. But no, an occupation, at least how I define it, the people at Webster may disagree with me, but how I define what occupational therapy or an occupation is anything that you do that occupies your time. So that can be as simple as brushing your teeth, hanging out with friends, whatever. I want to know what occupies your time, what's important to you, because I want you to be able to get back to doing the things that are important to you. Real quick, occupational therapy is assisting people with injuries or disabilities to accomplish necessary and desired tasks, or helping people to do what's important to them. I typically don't, but occupational therapists can see a myriad of different things. We see patients from birth to 100 plus years of age. It's a very diverse field. So we can specialize in neurologic care. We can do things cognitively, so if we have people that have a brain injury or something like that, kind of help them to get back to the things they need to do. Of course, we can help people with physical things, and that's kind of where I come in. I really work with the biomechanics of the arm and shoulder. Also, it's important to help people get back to their social activities. Just here in the last few years, I can't tell you how many people I've had that play piano at church. And it was really important for them to be able to get back and to do that thing because that's kind of how they identify themselves as the piano player at church. So it's my job to help them to get back to doing what they want to do. As far as the education goes, it kind of varies depending on how long the master's program is set up. I went to school for 5 years after high school. Got my master's degree from the University of Southern Indiana, so local. And the emphasis, kind of different from physical therapy, is a very eclectic kind of training. As you saw there, we have a variety of different fields that we can really go in and specialize into. So I consider myself a jack of all trades and really a master of none, although in the past just few years I've been really focusing in on the physical stuff, the biomechanical approach to the body. But one thing that is true in all of these fields here today is that education never stops. We are constantly trying to learn something new. I learn something new daily. And I get humbled daily. But it's always an adventure, always something new. And if you want a profession that keeps you on your toes, go into the health field.
just a couple notes. Since we were talking about shoulders, a couple slides on labral tears. They're actually more pertinent to athletic injuries that we see, and something that I think some of our high school athletes may have had. This is an x-ray. We looked at the x-ray before. This is an x-ray of an anterior shoulder dislocation, which is again the most common direction it can dislocate. They can also dislocate inferiorly or posteriorly, but anterior is the most common. And so we'd have to put that back in, and we can do like what Mel Gibson did on Lethal Weapon and pull it real hard, and it goes back in, which rarely works, but you can try. And what we see when we go into the shoulder with the shoulder scope, here's the humeral head, this is the glenoid, and this is what a labral tear looks like. And what we do there is we put anchors along the cartilage, and we put sutures around the labrum, and we tie it. And it looks like that. It's on the other side. We tie the labrum back down. Here's another animation of what happens with the labral tear and how we fix it. So if you know somebody that's had shoulder surgery in high school, this is most likely what they had done, because they had a labral repair. And this is where we see the suture coming around the labrum. We have two cannulas in the front of the shoulder. We pull a little loop wire through, and we pull a suture back through. Now we've got a suture around the labrum, and then we get both sutures in one portal, and then we come down with a little cannula, and we drill a hole into the bone where we want it. It's very, very important where we put those holes. And then we grab the suture and we push it down, and then push an anchor in to hold that. The insertion handle comes out, and then we cut the sutures, and then we do it again and again until we have the whole thing repaired, which usually consists of 3 to 4 anchors. There's lots of ways you can repair them. There's lots of ways they can tear, but that's a pretty simple tear. That's a common tear. That's what we see in most of our high school, college level athletes that have a labral tear. So yeah, what that does is it pulls the capsule or the labrum. I'm sorry, the anterior labrum, which is like a bumper, back to the bone, and then it's not healed. Then if they just start doing everything they want to with their arm, it's going to fall back apart again. So what we're trying to do is hold the soft tissue, the labrum, back to the bone, and then there's a whole biological process that occurs where the bone actually heals to the tendon. We believe the bone actually heals into the tendon. That process takes about 6 weeks. That's why we hold you still for 6 weeks. Okay, it's a little longer for smokers, a little longer for people that aren't as healthy. But the whole idea, even with the rotator cuff tear, is when you put an anchor in, we pull the tissue down, we hold it still, and that allows it to heal together, at least to be healed enough so that you can start moving it. The whole healing process takes about a year. We see the strength of these repairs improves over the whole year. And that concludes our presentation. We'd like to say thanks to all the teachers. Does anybody have any questions? Guys, hello. Let's see if there are any questions first. Questions? Yeah.
What kind of material are the sutures made out of?
What kind of material is the sutures made out of? That's a great question. So when I started training, we were just the idea of rotator cuff repairs and suture repairs through a scope. It was a new idea, and so we go in with our standard sutures, and what we find is that every time we go to tie a knot, they would break. So this gentleman had an idea. I need to make some really strong sutures. So he came up with started this company called Arthrox. And now it's one of the biggest global players in arthroscopy. And the sutures that we generally use are made out of Kevlar. So it's the same stuff that you use in a bulletproof vest. And they're super, super strong. And so when we tie those knots, we don't want the sutures to break. We don't want to do all this work and put those anchors in and the sutures break, and then we have to do it all over again. So that's a great question. The sutures are actually made out of Kevlar, which is really kind of cool. Other questions? Back here. Yeah. The question was, do you use dissolvable sutures, suture anchors, right? Yeah. So yes, we do use dissolvable suture anchors. They used to all be made out of metal, but if there was a problem, we'd have to come back and do an MRI, and the MRI would have a lot of interference from the metal, so we didn't like that. So now we use these absorbable anchors, or biocomposite anchors, where you put them in, they're made out of the same stuff that bone's made out of, and then your body absorbs them over the course of 1 to 2 years. Other questions? Yes? Sure.
Okay. Right here.
Well, what are they? We said them during the talk. Does anybody know?
It's all right, they don't listen to me either.
No, not one of the 4. But it was in the shoulder, we saw it. So one of them is the long end of the biceps. Okay? It actually comes up into the joint, the bicipital groove, attaches to the supraglenoid. And the second one is the popliteus. The popliteus comes into the posterior lateral aspect of the knee and inserts on the lateral femur. Other questions? So now, for those that want to come up here, just kind of middle on up. Dr. Gill will be up here. We'll bring a cadaver out. Dr. Gill, you want to bring a cadaver out here? Okay. We'll bring a cadaver out here. And so students that want to see that, again, guys, very respectful. This is somebody's mom. This is somebody's parent. Somebody's grandparent. Okay. And no selfies, no photos. And we'll let Dr. Gill take it from here.
Yeah,